Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today I'm talking to Dr Louise Newson about some of the trickier questions that come up in discussion about management of the menopause and perimenopause. Could you start by introducing yourself?
Yeah, I'm Dr. Louise Newson. I'm a GP, physician, and a female hormone specialist.
And could you give us a brief overview of your current role, what your job involves?
Yeah, so I have multiple roles, but I run a menopause clinic. I also very heavily involved in education and research, and I do a lot of work empowering women about hormones and treatment choices that are right for them.
In your first interview, we talked about what you might call the basics of HRT, and of course, it raised many more questions. And now I'd like to explore some of these. First, does HRT increase the risk of developing breast cancer?
So it's a great question, but there are different types of HRT. The easy answer is no, it doesn't. The only type that's been shown to be associated with a non-statistically significant increased risk of breast cancer is medroxyprogesterone acetate, so synthetic progestogens. So estradiol, progesterone, testosterone have not been shown to be associated with an increased risk of breast cancer.
Mm-hmm. And what about women who have a history of breast cancer already? Can they take HRT?
There's no easy answer because the studies haven't been done. There's been a real confusion actually because some of the studies have used synthetic hormones and then or tibolone, which is very synthetic. And they've lumped it together. So we don't know because actually an estrogen receptor positive breast cancer doesn't mean it's been caused by estrogen, and it doesn't mean that estrogen per se is all bad. There's different types of estrogen, and it might be that it's an estrone driven breast cancer, not an estradiol. But no one knows. And because we give aromatase inhibitors to block estrogen, it's almost, I think, quite lazy thinking to think, therefore, estrogen is bad. We know that women who are pregnant with very high levels of estradiol do not increase their incidence of breast cancer, for example. So we just don't know is the easy short answer, but then it's very hard for women because they're just told, no, you can't have hormones if you have breast cancer. Estrogen receptor negative is easier, but increasingly I prescribe testosterone for women who've had an estrogen receptor positive breast cancer, and it can really improve their symptoms. And there's some data that it will improve their outlook actually and prognosis from breast cancer.
Mm. And now for a small print one that comes up from time to time. What about women who are BRCA, BRCA positive, who have already undergone prophylactic bilateral mastectomy?
Yeah, so whether they've had a prophylactic bilateral mastectomy or they've had a bilateral oophorectomy, then they can usually safely have hormones. The reason they're having the surgery is to reduce their incidence of a cancer because they've got this family history. But actually, I've already said that having hormones won't increase the risk if they have the body identical hormones. And there is a small studies, they're not great, but do show that women who've had BRCA who have BRCA and have their oophorectomy and have HRT have a better prognosis. And it doesn't surprise me because our hormones are so anti-inflammatory. So it's really sad when I see women who have a family history, they've got BRCA and they've been told they can't have hormones. So, we can, but I wouldn't give synthetic hormones, of course.
Mm. Thanks for clarifying that. Next, can you talk briefly about genito-urinary syndrome of menopause, GSM? Is this what used to be called vaginal atrophy?
Yes, so vulvovaginal atrophy, VVA, is what we always used to write in the notes. But actually, if you look up the word atrophy, it's withering and wasting away. Now, I don't want to think of any of my anatomy withering and wasting away, but indeed it does without hormones for many of us. So it was changed a few years ago to GSM, genito-urinary syndrome of menopause. But actually, we've just written a paper with some colleagues in America trying to change it to just genito-urinary syndrome because it's not of menopause. Actually, it's very common. About 70–80% of menopausal women will have some symptoms, but it can occur in perimenopause. It can occur in women taking contraceptives, so women who are young, women who are breastfeeding. So if we wait for menopause, we're missing a lot of women. And if we think about it, the good thing is it includes the word urinary. So we've got the genital symptoms that we know about vaginal dryness, soreness, irritation, pain and intercourse. But what about the urinary symptoms? Because those are more important and significant in my mind. So people can have urinary incontinence, they can have urge or stress incontinence, they can have increased frequency, but most importantly, they can have urinary tract infections. Now, most women have had a UTI, and many of us have had a lot, and some of us have had pyelonephritis. And if we think about sepsis, 30% of sepsis is due to urosepsis, so urinary tract infections. Now, one of my children had sepsis not due to a urinary tract infection, but due to an infection in her hip. And being with someone who has sepsis is the scariest thing that's ever happened to me as a doctor, especially when it's my relative. But, that's avoidable. Actually, if we're thinking about giving vaginal hormones, we've got good data from the 80s. So from many years ago, showing that incidence of urinary tract infections significantly reduces if women use vaginal hormones. Yet we know that only the minority of women who have GSM are prescribed these transformational hormones. And women who've had breast cancer can safely use them too, of course.
Very useful. Now, could you comment on the role of the neurokinin receptor antagonists elinzanetant and fezolinetant for vasomotor symptoms, hot flushes?
The second question I'll answer first because it's quicker. No, they haven't. So they haven't been compared with the gold standard treatment, which is very unusual, isn't it, for a clinical study? They've been compared with placebo. Now, a couple of years ago, when these drugs first started being talked about, I spent a whole weekend, and I worked hard, so these were like 14-hour days, reading about neurokinin receptors, because I didn't know about them. It wasn't something I was taught. So I went back and I just looked at the basics, how they work, not how the drugs work, but how neurokinin works in our body. And it's very interesting, actually, because we have neurokinin receptors throughout our whole body. But the neurokinin receptor antagonists were made as neuroleptics, so to try and help with psychosis. And they didn't really make much difference, but they did notice that women in the study, had less hot flushes. So they thought, okay, well, let's use it for that. So they do work in the hypothalamus. They will affect the thermoregulatory sort of zone, and they will. The studies show that they do reduce hot flushes. Fine, but I've already said in the first recording with you that it's not the most common symptom. So, the other thing is we've got these receptors all over our body. So you're blocking something all over your body, and we don't know the effect. There are some studies that it can inhibit natural hormone production. So if you're perimenopausal and given them, it's very likely that your estradiol, progesterone, testosterone levels will reduce, especially in your brain. And I've already said the commonest symptoms affecting women are those affecting our brains. So that's not necessarily ideal. The big concern I have really with them is that they block something called kisspeptin. And kisspeptin is a protein that inhibits metastatic spread. So if you've had a cancer, and these drugs are heavily sort of marketed for women who've had breast cancer, the last thing they want is any metastatic disease. So if you're inhibiting a protein that will help protect our bodies, we don't know the long-term effects, and that's what makes me really nervous about them. I don't work with pharmaceutical companies, as I've said, and you can Google this, so I'm not telling you anything that you can't find out yourself, but there's two drug companies that have made these drugs, and they have spent millions. In fact, the combination of the two of them is about $2 billion probably that they've spent getting them to market. And we know that drugs cost a lot of money coming to market. One of them was advertised on Super Bowl a couple of years ago, and I think if you put it into Google, it's about $7 million to have a 3-second advert on the Super Bowl. And they're being heavily, heavily sponsoring all the menopause societies. I haven't found one menopause society, but I can stand to be corrected, that doesn't have them as a sponsor for their conferences. So I've stopped going actually to menopause conferences run by societies that are sponsored by these drugs, because I can see who's being paid by them, because you can read the conflicts in the journals. And I do worry that we're only seeing sort of skewed data, really. We don't have long-term data. We don't have really reassuring data. There's a small study that came out in the Lancet that's been hidden quite a lot, showing that there is an increased incidence of epithelial cancers in women who take these drugs. And the number needed to harm is actually quite low, so it's sort of 24 or so. But that's a small study, so of course you can't make sweeping generalization. But I'm quite cautious as a doctor. I don't even prescribe GLP-1s. So, and then there was a big push for fezolinetant. I saw it over social media. A lot of people that run private clinics, because it's only available privately, £400 a month or something ridiculous. And then I've just worried because it's associated with deranged liver function as well. And then they suddenly put a warning about doing liver function tests, and the FDA put black box warning on fezolinetant. So I'm like, well, there's another reason, like I don't, if a woman can't or doesn't want hormones, then there's lots of other things we can talk about. I just don't think we should be medicalizing women with a drug that I'm just not comfortable. But, some people do, and I'm on a group chat and lots of people talk about them. But I just think I just would like to know the long-term data.
And now another important one. Can you be too old for HRT? I know some women have been told they are by their GPs.
Yeah, you see, in my mind, no one's too old, because I'm getting older and I don't want to be thought of as too old. But no, and I know where the confusions come from because the WHI showed that women who were over the age of 60 had an increased incidence of cardiovascular disease. But I've already said a few times that the WHI was with synthetic hormones, conjugated equine estrogens. And so it was really giving the wrong type of hormone, the wrong dose to the wrong woman. And these women often had established cardiovascular disease. So people, and I still read papers. There was one that came out just a few days ago in JAMA saying that there's this increased cardiovascular risk in women over the age of 60. So hang on, how does your body know that estradiol is going to work differently age 59 to 61? Like we're constantly producing new cells. The cells when I'm 59 and 61 just look the same. They might work differently because I'm slowing down, my metabolic processes are changing, but they're not going to respond differently to estradiol. And then people say, oh, well, it might be because there's an established clot and you could dislodge a clot, especially if it causes vasodilatation. Well, hang on, I've been giving people amlodipine. Years ago, it was nifedipine for vasodilatation when they've had an acute MI, and that didn't cause a clot to dislodge. And so you're not going to get the same level. So that doesn't really add up in my mind. But what does add up is the synthetic hormones are very pro-inflammatory and will increase inflammation. So of course you wouldn't want to give those to anybody, but especially people with who are older with a higher risk of cardiovascular disease or people with established cardiovascular disease. So if someone comes to see me and they've missed out, there's generations of women that have missed out of hormones, then I'll start them with a low dose transdermal estradiol, progesterone, sometimes add in testosterone, and allow women to choose. We don't have randomized controlled studies with natural hormones. We never will because it's actually unethical giving a placebo to something that we know has got so many benefits. But not everything in medicine has a randomized controlled study. And women can choose, and I think that's the biggest thing that's important is choice.
Very helpful. Now, could you comment on the latest, that's the November 24 NICE guideline on menopause identification and management?
Top level, first line treatment for the majority of women is hormones, so that's fine. But when you look at it in detail, there's a few things. And in fact, I was at the European Menopause and Andrology Society conference in Valencia earlier this year, and Professor Steve Goldberg, who used to be, or Goldstein, he used to be the president of the International Menopause Society, he asked a question before me. And his question was, did you distinguish between synthetic hormones and natural hormones in your full analysis of the guidelines? And Martha Hickey, who's the key topic advisor, said, no, we didn't, because we don't have another randomized control study. Now, I know they didn't if you read the guidelines, but lots of people don't. So there was a bit of a gasp from the audience. So that's wrong in my mind, because if you don't have the data, you say you don't have the data, but you don't merge it together. Now, my question that I asked them was, what about young women? Because I worry about young women with premature ovarian insufficiency, because the guidelines say that you have to have a raised FSH to make the diagnosis of follicular stimulating hormone. So I've already said I see a lot of women who are on quetiapine, their FSH is suppressed. So what about those women? And then there's also perimenopausal. It depends on the time of the day whether you're going to get that raised FSH. You might have it normal or low. And then their response on the panel was, but Louise, how else do we diagnose menopause for these women? And my response, of course, was take a good history and give a therapeutic trial. But they didn't like that. But the other thing is if you, and I've done it, I can't remember the exact numbers, but anyone can do it. You can just do a word search and look at, if you search for the word osteoporosis and search for the word breast cancer comes up far more frequently than osteoporosis. And if you look for the word risk and then you look for the word benefit, it's disproportionate as well. So there's a bit of bias, and then you can look at some of the authors. You can see their conflicts. We know that there was a disagreement and a couple of the authors walked out because they didn't agree about the cardiovascular disease risk because they're saying there isn't evidence. Well, there is evidence. We've had it for years, decades, even Cochrane data. So anything that I just don't like politics. So anything where people have fallen out, you just wonder what else is going on, really. So that's why I sort of think top level fine. But also, lots of people have sort of said to me, "Oh, Louise, you don't work out of NICE guidance because sometimes you prescribe off-label doses." I'm like, hang on, NICE guidance say nothing about the doses, but people have said the word on the street is they do. And it's like, no, no, no. I've read the guidelines from top to bottom and they don't mention doses. What they do mention, which I think is very good, is about individualization of care. And that's really important because, as you know, medicine is a art as well. And we have to not forget this art and individualization of care that we all should be doing in medicine.
Some useful insights there. Now, it can be difficult for women to find accurate information about menopause management from amongst the torrent of information that's now around. Perhaps I could ask you to comment on meno washing and suggest where women might go for authoritative information.
Yeah, I mean, I've developed Balance app, which is a free app, which has a lot of information, and my website also has a lot of written information, but also videos and obviously my podcasts as well. And everything I write is evidence-based. I've worked as a medical writer for about 25 years now, so I know how to write. I know how to unpick literature. I know what to look at, and how to write to help, in a general, not an individualized way. So I think obviously the resource is good, and like I've said many times, I don't work with pharma, so I don't have any conflicts. I think looking at who's written the information is crucially important, and also looking how updated it is. I've just recently relaunched my website a few months ago, so every single article on there is within like 3 months, and we review every year because things do change, or we might have new articles. We like to reference, it's still for lay people, but we still use references as well because I think that's really important. So just look at what you're looking at is really important because sadly you think, oh, this is going to be good, and it might then mention and confuse people. So I think just looking at who's written it, have they got conflicts, is there any evidence, and how up to date is it as well?
Very helpful. And now my final question. What is the distinguishing feature, the USP, if you like, of Newson Health?
I think one of the things that I'm really proud of the clinic that I established is that I have some amazing clinicians work there who work there who are GPs but also pharmacists and nurses. And we have a very sort of horizontal matrix, so we're learning from others all the time. We're not scared to ask, we're not scared to, just reflect and share what we're learning. We learn so much from patients. So, we have a clinical teams chat going all the time, and that's really useful. So we are holistic, and I think that's again is quite unusual. We don't just think about hormones. When hormones are balanced, we'll be talking about lifestyle, we'll be talking about nutrition, we'll be talking about any supplements, not menopause supplements, but supplements for future health. So we very respectful of each other, and it's great. Like most of us, I hate to say this, but it's true. Most of us have worked in GP practices where we've had difficult times, where we've been put down as female doctors, where we've been made to feel inadequate by other healthcare professionals. So we're really inclusive, and lots of people comment how great that is. But the main thing is we're really here for our patients. We really listen to our patients, and we're just recruiting some new doctors. And last week I was warning them about the stories that we hear because we see people from all socioeconomic classes. And like I've said, a lot of people who have severe mental health disorders who I've never met, so many in general practice because my patients never got to that stage. So it's quite harrowing actually. So we do provide a lot of support. We've also worked very hard on our admin team, our managers, to really support our staff and our patients as well. But it's also been, I'm very proud of it because of the clinic and its relative. You can argue what success really looks like, but I've used the profits to pay for Balance app, for pay for our education program, to pay for my podcast. And all of those things are helping enrich other people's lives. So a lot of sort of private work is always introspective. It's just helping the user who's paying in front of you. And I've sort of not doing that. It's a bit frustrating for my finance director because I'm constantly using money in other ways, which I think is really important because it's such a terrible situation out there for women, and it's not really getting any better. HRT prescribing's plateaued, and the stories that we hear from women are worsening. Over the last 6 months, it's getting so much worse. So using the resources, the profits that I get are really, really important for me to do this.
Dr. Louise Newson, thank you very much for demystifying these important points. That really has been terrifically interesting and very helpful. For more information about Dr. Newson's work, please visit the website using the links in the description. And be sure to subscribe for more news, videos, journals, and podcasts. For updates straight to your inbox, please follow the links below. And thanks for watching.